Welcome to the Deep Dive, the show that transforms complex topics in your provided sources into a pathway for true understanding. We're all about getting you informed fast, uncovering those surprising facts, and delivering those aha moments that genuinely stick with you. Today, we're embarking on a journey that touches almost all of us at some point, whether directly or through loved ones. The intricate, meticulously planned, and constantly evolving world of preoperative and operative surgery.
Indeed. For this deep dive, we've been given a truly comprehensive set of sources, primarily drawn from the SABISTON textbook of surgery, which is a renowned authority in the field. This isn't just about what happens inside the operating room, it's a deep dive into the layers of meticulous planning, the critical decisions, and, well, the cutting-edge technologies that define modern surgical care.
And our mission today is to go exceptionally deep. You, our listener, want to master this information, to understand it with the precision and insight of the elite professionals in this field. So we're not just scratching the surface here. We're going to unpack every single concept, every vital detail, and truly grasp the fundamental principles that guide surgeons in ensuring patient safety and achieving optimal outcomes. Get ready, because this is where understanding surgery at a truly advanced level really begins. Okay, let's unpack this journey by starting at the absolute foundation of surgical care and arguably one of the most critical elements, the patient-surgeon relationship. It all begins with trust and an incredibly clear communication. What does that initial encounter between a patient and surgeon truly entail, beyond just a routine medical checkup? What's the real objective?
That's a crucial question. While the core medical objective is always present, which is to either confirm or, importantly, rebut a suspected diagnosis, whether it's an urgent situation or a more elective one. What's truly fascinating here is how the emphasis extends far beyond just the medical facts. The source highlights the paramount importance of building a common bond. This involves the surgeon taking the time to genuinely inquire about a patient's personal interests, their relationships with their community, their place in society. This human element, this understanding of the whole person, is absolutely fundamental to establishing a profound foundation of trust. A trust that then becomes the bedrock upon which all the medical facts and decisions are built.
So it's not just about the medical history, but really grasping the personal history, the broader context of their life, right? You're essentially understanding the whole person. And then, once that human connection is established, the vital augmentation of that knowledge comes with diagnostic lab results and imaging. The ultimate goal, as the source emphasizes, is for an experienced surgeon to effectively recreate the clinical context of the patient's situation before the illness in question. That's a deep level of understanding. It's about comprehending the patient's normal, their baseline health, not just their current problem or a snapshot of their disease.
Exactly. Once that initial holistic evaluation is done and you have a comprehensive picture of the patient, the differential diagnosis, which is the process of distinguishing a particular disease or condition from others that present with similar symptoms, then directs further patient management. This naturally raises a critically important question for any surgeon. When do you pursue more investigations? And just as importantly, when do you hold back?
That's where the principle of Occam's razor comes into play.
Yeah.
For our listeners, this is the idea that among competing hypotheses, the one with the fewest assumptions should be selected. Or, as the source calls it in a medical context, the principle of parsimony. It dictates that you pursue only diagnostic studies with a high likelihood of producing actionable results. It's about efficiency, precision, and clinical effectiveness.
Precisely. The rationale is quite clear. Tests that have a near-perfect pretest probability, meaning the diagnosis is already almost certain before the test, or those unlikely to genuinely alter the treatment plan should be avoided.
Right.
Why? Because you don't want to burden the patient with unnecessary tests, which can mean unnecessary expenses, exposure to radiation, discomfort, or delays in getting to definitive treatment. Every test should meaningfully change the course of care. Once a definitive diagnosis is secured and confirmed, then the objective of the surgery and the urgency of potential surgical therapy are carefully and collaboratively considered.
Achieving a joint, crystal clear understanding of the surgical objectives and what the patient can realistically expect from the surgery is paramount for both patient satisfaction and ultimately for successful outcomes. The source identifies three broad, fundamental objectives for any surgical intervention.
Yes. These are foundational to defining the why behind a surgical procedure: disease prevention, disease control, and symptom palliation. Let's break those down as they represent distinct approaches and expectations for surgery. First, disease prevention. These operations are explicitly aimed at preempting a disease process before it even starts. Think of it as highly proactive intervention. A common example is prophylactic mastectomies for individuals with a strong genetic predisposition, like a BRCA mutation, which significantly increases their risk for breast cancer. Or, similarly, prophylactic colectomies for heritable cancer syndromes, like familial adenomatous polyposis, where the colon is removed to prevent the inevitable development of colon cancer.
Right, stopping it before it starts.
Exactly. Another less obvious example is an endarterectomy for asymptomatic carotid stenosis, where plaque buildup in a neck artery is removed to prevent a future stroke, not to treat an existing one. And even a seemingly minor procedure like an appendectomy performed during a LAD procedure for intestinal malrotation in a child here, the appendix is removed not because it's inflamed, but to prevent a future, potentially life-threatening appendicitis given the already abnormal intestinal anatomy. The core goal is to stop a disease from ever taking hold. Second, disease control. This category addresses an ongoing process, a disease that is actively present and needs to be managed or eliminated. Patients undergoing these procedures typically expect partial or complete resolution of the targeted disease. Examples here include resections for malignancy, where a cancerous tumor is removed to eliminate the disease or significantly reduce its burden. A cholecystectomy for acute cholecystitis, where you're dealing with an actively inflamed gallbladder, clearly falls into this category, aiming to resolve the acute problem. Or consider a knee replacement for severe arthritis. The surgery aims to control chronic joint pain and dysfunction, restoring mobility and function. The patient's expectation is a direct intervention on an existing problem. Finally, symptom palliation. Here, the primary goal is to improve the patient's quality of life by alleviating severe, often debilitating symptoms, rather than seeking a definitive cure for the underlying disease itself. This objective is particularly relevant in advanced or incurable conditions. The source provides examples like a proximal decompression for a malignant bowel obstruction, where the tumor causing the blockage isn't removed, but a surgical bypass is created to relieve the obstruction and ease discomfort, allowing for continued bowel function. Another is a gastrojejunectomy for unresectable pancreatic cancer with gastric outlet obstruction, which allows food to bypass the tumor-induced blockage in the stomach, improving digestion and nutrition, even though the cancer itself remains. The focus here is squarely on improving comfort and function, making daily life more manageable.
What's truly fascinating here is how absolutely vital it is for the surgical objective to be communicated with crystal clarity. The source strongly emphasizes that inadequate or unclear communication directly precludes informed consent. This means if the patient doesn't fully understand why the surgery is being done and what the realistic outcomes are, their consent isn't truly informed. This can have dramatically negative implications for a patient's decision-making and overall satisfaction. It's not just a medical discussion. It's a deeply ethical imperative, ensuring the patient's autonomy and understanding are thoroughly respected.
Absolutely. Beyond meticulously defining the surgical objective, accurate categorization of surgical urgency is another profoundly critical step. This isn't just about patient outcomes. It also has a massive impact on resource distribution within a hospital and on how quality metrics are reported. The American College of Surgeons, ACS, National Surgical Quality Improvement Program, NSQIP, a leading national database, differentiates very precisely between emergency and elective operations, even noting differing predictive accuracy for risk estimates, with emergency cases historically showing superior predictive accuracy for mortality.
So to really master this, what defines these precise categories? Emergency, elective, and urgent surgery. They sound distinct, but often get conflated.
Let's define them with the precision needed by professionals in the field. First, emergency surgery. This is characterized by an ongoing acute process that can rapidly and significantly deteriorate a patient's condition. In these situations, unnecessary delay can potentially threaten the clinical outcome. Time is literally of the essence. Waiting is detrimental and can lead to irreversible harm or death. Think of a ruptured appendix or major trauma with internal bleeding. Second, elective operations. These generally involve a patient who has completed a comprehensive preoperative evaluation during a separate patient-surgeon encounter and is subsequently scheduled for the operation. It implies a planned procedure where the patient's immediate life or limb is not threatened, allowing for thorough preparation. Notably, the ACS NSQIP guidelines explicitly exclude inpatients, emergency department referrals, and direct transfers from clinic from this specific category. This is because, even if their procedure might feel elective in terms of timing, the acute nature of their initial presentation means they aren't considered truly elective in the programmatic sense. And third, urgent operations. This is aptly described as a more ill-defined category, falling precisely between elective and emergent. It acknowledges cases that are time-sensitive but not immediately life-threatening. To bring more clarity, the World Society of Emergency Surgery's timing of acute care surgery classification from 2013 further subdivides these urgent cases based on an ideal time to surgery, ranging from immediate intervention within minutes to within 48 hours from diagnosis. This distinction is vital for proper triage and resource allocation.
This recognition of urgency is truly one of the first steps of the entire preoperative evaluation process. It profoundly influences subsequent decision-making, the way patients are counseled, the scope of investigatory testing, and the overall perioperative management plan. It's a foundational triage point that shapes every single decision that follows. This is truly where the rubber meets the road in surgical planning. Comprehensive risk assessment. It impacts everything from the fundamental decision to operate at all, to the specific choice of which operation to perform, and even down to the detailed planning of postoperative care. It sounds like its core purpose is about shielding patients from inappropriate operations and meticulously optimizing care for those with borderline risk.
Precisely. It's multifaceted and foundational. Beyond protecting patients and optimizing their individual care, rigorous risk assessment also facilitates vital resource allocation within the healthcare system. This includes determining the need for specialized intraoperative monitoring, whether intensive care unit, ICU services will be required immediately after the operation, and if medical consultations with other specialists like cardiologists or nephrologists are needed. Furthermore, for institutions, transparent categorization of patient risk factors significantly improves quality reporting and allows for crucial multi-institutional comparisons of risk-adjusted patient outcomes, which drives continuous improvement in surgical quality and safety across the board.
So how does this detailed assessment begin at the patient level? What's the starting point for evaluating risk?
It fundamentally begins by considering the specific nature of the patient's disease, its severity, progression, and potential impact, and then carefully weighing that against their existing comorbidities. These are the other health conditions the patient has, like diabetes or heart disease. You're weighing these intrinsic patient factors against the inherent risks of all possible surgical interventions. The source notes a critical point. For many diagnoses, multiple surgical approaches might be available, each presenting distinct advantages and disadvantages. These can vary significantly in terms of their morbidity profile, likelihood of complications, expected quality outcomes, and the long-term durability of the therapy. These various approaches must be meticulously weighed and discussed in the context of each patient's unique presenting condition and their baseline level of health. It's a truly individualized calculation.
That makes perfect sense. And the American Society of Anesthesiologists, ASA, physical status categorization, as presented in Table 10.1 in our source, seems to be a simple yet powerful initial rubric for summarizing a patient's baseline health.
Yes, it's a widely used and incredibly pragmatic initial stratification tool, introduced way back in 1941. Patients are stratified from ASA1, defined as a normal, healthy patient, all the way to ASA5, a moribund patient who is not expected to survive without the operation. This categorization helps stratify patients into broad risk groups: low risk, ASA1 to 2, intermediate risk, ASA3, and high risk, ASA4 to 5. The addition of an E designation to any class signifies an emergent operation, inherently indicating an even higher risk due to the urgency and lack of time for optimization. What's profoundly important for professionals to understand is that since its introduction, increasing ASA class has consistently been associated with early postoperative mortality. This relationship holds true in the modern era for both emergent and elective operations, with Class 5E, the most critically ill patients undergoing emergency surgery, having a nearly 20% likelihood of early postoperative mortality.
Wow, that's a profoundly significant statistic. To put that in perspective, nearly 1 in 5 of the sickest emergency patients won't survive the 30 days post-surgery. It really drives home the life or death calculus surgeons face even before the first incision. Beyond just the patient's physical status, operations themselves are categorized by their inherent risk. How does that factor in?
Exactly. It's why this stratification isn't just academic. It directly informs resource allocation, staffing needs, and the crucial conversations with families about realistic outcomes. It's about managing extreme risk. And yes, beyond patient status, operations fall into low, intermediate, and high-risk groups, regardless of the patient's individual health. This categorization is most commonly based on expert opinion and consensus guidelines, such as those proposed by the European Society of Cardiology and European Society of Anesthesiology. These guidelines stratify procedures based on an estimated 30-day risk of cardiac events, as shown in Table 10.2 in our source. To give you a clearer picture, understanding these categories is vital. Low risk. These procedures carry an estimated cardiac event risk of less than 1%. Think of everyday surgeries like superficial procedures on the skin, breast procedures, most dental operations, eye surgery like cataracts, minor orthopedic procedures such as a meniscectomy, and minor urological procedures like a TURP. These are generally well tolerated. Intermediate risk. These operations are associated with cardiac event rates ranging from 1% to 5%. This includes a broad range of common procedures such as many intraperitoneal surgeries like splenectomy, hiatal hernia repair, or cholecystectomy. Symptomatic carotid procedures also fall into this category. These procedures carry a moderate but manageable cardiac risk. And finally, high risk. These are procedures where the estimated cardiac event risk exceeds 5%. This category encompasses major and complex surgeries. Examples include aortic and major vascular surgery, duodenopancreatic surgery, liver resections, and esophagectomy. Major orthopedic procedures like hip and spine surgery and the urgent repair of a perforated bowel also fall under high risk. Lastly, a pneumonectomy is considered a high-risk operation.
So, when you combine a patient's individual health status with the inherent risk of the operation, what does this all mean for overall patient outcome? How does a surgeon quantify that total risk?
When you combine these factors, the picture becomes very clear. Combination surgical risk models, which leverage sophisticated statistical methods like logistic regression, are developed precisely to predict outcomes like mortality or major complications. These models integrate both patient comorbidities and the inherent operative risk. The source highlights a stark reality that truly puts this spectrum into perspective. For very low-risk outpatient procedures, the risk of death is incredibly small, less than 1 in 50,000 cases.
Wow.
This is why many routine surgeries are now done safely in outpatient centers. Conversely, for high-risk operations performed for life-threatening conditions in critically ill patients, the expected mortality rates can routinely exceed 20%, as strikingly illustrated in Figure 10.1. This wide range demonstrates the immense spectrum of risk in surgery and underscores how absolutely critical a comprehensive and precise assessment is.
That's a huge spectrum of risk, from almost negligible to 1 in 5 chance of mortality. And there are specific tools to help quantify this risk, moving beyond just general categories. What kind of tools are we talking about?
Absolutely. There's a wide variety of sophisticated tools available to quantify operative risk in the preoperative setting, predicting outcomes that range from broad measures like death or length of stay to specific events such as the need for reoperation or particular surgical complications. Methodologically, these tools group into 3 main types. First, we have categorical scales. These are generally easy to calculate and are often subjective in their application. The ASA classification we just discussed is the classic example. Second, there are risk scores. These combine several predictors, typically chosen using multivariable predictive modeling, to estimate the risk of a specific outcome. The MELID score for liver disease is a prime example. And third, the most recent and advanced are prediction models. These leverage cutting-edge statistics applied to very large, multi-institutional data sets. They generate estimated likelihoods of multiple surgical outcomes based on numerous patient-level risk factors, offering a much more nuanced prediction.
And the most commonly cited example of a surgical risk, or more accurately, one of these advanced prediction models, is the ACS NSQIP Surgical Risk Calculator, SRC, isn't it? Tell us more about how it works and what it predicts.
Yes, absolutely. The Universal SRC was a monumental development in 2013, built using standardized clinical data from more than 500 NSQIP participant hospitals. It's an indispensable online tool designed to predict adverse postoperative outcomes based on 20 preoperative patient-level characteristics. These include a wide array of factors, from demographics and existing comorbidities, as detailed in Table 10.3. The risks associated with the specific procedure type are automatically incorporated into the calculation using CPT codes. To give you a sense of its evolution and power, the SRC has been continuously updated and refined, with its 2016 update, for instance, calibrating the database to predict outcomes even more accurately, especially for the lowest and highest risk patients. It now contains data from over 3.8 million cases across 740 hospitals and is publicly accessible online. Originally designed to predict 8 outcomes, the tool has evolved to currently report likelihoods of 13 specific or composite outcomes within 30 days of surgery, which are outlined in box 10.1.
What are some of those specific characteristics it considers, and what are the 13 outcomes it predicts? This sounds incredibly comprehensive for a risk calculation.
It truly is. The 20 preoperative patient-level characteristics include a patient's age group, sex, their functional status, whether it's an emergency case, the ASA class, chronic steroid use, the presence of ascites, systemic sepsis, ventilator dependence, and disseminated cancer. Other important comorbidities covered are diabetes, hypertension, a history of previous cardiac events, congestive heart failure, and dyspnea. Lifestyle factors like smoking status and COPD are included, alongside renal issues like dialysis and acute renal failure, and even their BMI class. As mentioned, the risks associated with the specific procedure are then layered on using those CPT codes. And the 13 specific or composite outcomes predicted within 30 days are designed to give a truly holistic picture. They include serious complications, any complication, pneumonia, cardiac complications, surgical site infections, SSIs, UTIs, venous thromboembolism, renal failure, readmission, return to the operating room, death, discharge to a nursing rehab facility, and sepsis. It paints a very detailed picture.
That's an astonishing level of detail and prediction. How accurate is this tool in its predictions, especially when surgeons are using it to counsel patients on potentially life-altering decisions?
The levels of discrimination are generally very strong, with C statistics consistently higher than 0.75 for all predicted outcomes, which is quite good.
That's reassuring.
In particular, its discrimination for 30-day postoperative mortality is excellent, with a C statistic exceeding 0.9. That suggests it's a remarkably reliable predictor of death after surgery within that critical time frame.
And how is it being adapted or built upon in modern practice? Is it static or does it continue to evolve?
It continues to evolve. Recent investigations have evaluated combining the SRC models with preoperative biologic markers like hypoalbuminemia or with organ-specific metrics like chronic liver disease, aiming to further enhance its predictive power for specific populations. It's also been successfully adapted for the pediatric population, creating the pediatric SRC. This version incorporates nearly 200,000 cases across 67 hospitals and shows excellent predictive accuracy for mortality and morbidity in children.
This tool is clearly designed to facilitate patient counseling and the informed consent process. But it's interesting that it doesn't consider intraoperative findings or events that happen during the actual surgery. That feels like a significant point.
Correct. That's a critical nuance, and it's important for professionals to understand its limitations. The SRC is designed purely for preoperative use. It does not and cannot take into account any findings or events that occurred during the actual operation. Furthermore, despite its excellent calibration within the broad NSQIP dataset, some recent studies have identified lapses in predictive accuracy when applied to smaller, more homogeneous patient populations or specific subspecialties. So while it is an invaluable tool for general risk assessment and patient discussions, it cannot replace a surgeon's familiarity with institution and surgeon-specific performance data. Personal experience and judgment still play a vital role. This deep understanding of patient risk leads us directly to the ethical imperative of informed consent. Surgeons have a non-negotiable obligation to discuss and pursue this with any patient considering an operation. It's mandatory to provide comprehensive, transparent, and absolutely clear communication of all perioperative risks and potential benefits.
So for a surgeon to successfully guide a patient through this often daunting process, they must possess an incredibly thorough technical understanding of the proposed operation, a precise grasp of the most probable perioperative course, and an acute awareness of all potential pitfalls and complications.
Absolutely. Clear and precise communication of risks and expectations is paramount, and critically, technical jargon must be rigorously avoided to ensure true patient understanding. The consent process must integrate all the preceding facets: surgical objectives, urgency, and patient risk assessment. Systematic reviews indicate 6 key components: the diagnosis, the proposed procedure, procedure-related risks, likelihood of success, the patient's mental capacity, and alternative treatment options.
This comprehensive approach raises an important question. What's arguably the biggest challenge in achieving truly informed consent?
One of the most challenging impediments is precisely that inherent knowledge gap between the surgeon and the patient. To effectively overcome this, consent processes can and should be augmented significantly. This includes using decision aids, visual materials, specialized written materials, and even leveraging the risk calculators we just discussed. These supplementary instruments have been shown to tangibly improve patient knowledge and, importantly, their satisfaction with their decision-making process.
Moving now to a critical and growing area of surgical care, the assessment of geriatric surgical patients. This is a vital area as the U.S. population continues to age dramatically. Currently, 13% of the population is 65 or older, and by 2030, that proportion will soar to over 20%. Geriatric patients already account for over 30% of hospital days and a third of all inpatient procedures. This rapidly growing demographic presents unique surgical challenges.
Indeed. It's about recognizing that chronological age alone is simply not the sole determinant of surgical risk or outcome. Tailoring the preoperative workup to their unique needs helps surgeons address age-related functional challenges and complex comorbidities. Crucially, decision-making must be appropriately aligned between provider and patient, embracing shared decision-making. The patient and family need a clear, realistic understanding of operative risks, potential effects on quality of life, and likely outcomes. Conversely, the surgeon must deeply appreciate and incorporate the patient's personal goals of care into any decision-making process. It's a truly collaborative endeavor.
That brings up a key point. What precisely defines a geriatric patient in the surgical context? It sounds like it's more than just a specific chronological age cutoff.
Yes, the chronological demarcation is elusive and insufficient. It's truly a dynamic combination of advanced age, multiple comorbidities, and any existing functional and/or cognitive decline.
Okay.
Due to these intertwined complexities, a multifaceted preoperative evaluation is absolutely necessary. This recognition led to a vital collaboration between the ACS NSQIP and the American Geriatric Society AGS, which produced comprehensive guidelines for multi-domain assessment, detailed in Box 10.2.
So this wasn't a completely new concept, but a crucial refocusing of existing comprehensive assessment for the surgical context.
Correct. The concept of comprehensive geriatric assessment, or CGA, was first implemented back in the 1980s and 90s in medical settings. Historically, CGA programs were shown to improve independent living, enhance physical function, and even reduce long-term mortality in the general geriatric population. While studies in surgical populations are rarer, a recent systematic review found significant positive impacts on procedural cancellation rates, surgical complications, and length of stay. What's truly fascinating here is that the most effective CGA programs are those that impact direct medical care recommendations, meaning they translate findings into actionable changes in treatment plans. The framework of CGA covers critical domains: medical, mental health, functional capacity, social, and environmental. The ACS NSQ PIAS collaborative framework refocuses these on themes relevant to operative and perioperative care. All aspects are vital, but some are more pertinent to geriatric surgical patients. One of the most critical areas is cognitive impairment and the risk of postoperative delirium. Nearly 1 in 5 elderly patients already has some form of dementia or cognitive impairment. The ACS NSQI PAGS framework strongly recommends routine neurocognitive assessment for all elderly patients preoperatively, especially those without a pre-existing diagnosis.
How is that assessed in practice? It needs to be both thorough and efficient, right?
Methods include pragmatic cognitive screenings, like the mini-cog, detailed in Box 10.3. It also often involves interviews with the patient support structure. The mini-cog offers advantages: extensive supporting evidence, ease of implementation, takes about 3 minutes, and focus on attention and executive function. A total score of 0, 1, or 2 suggests possible impairment, while 3, 4, or 5 suggests no immediate impairment.
And if there are findings suggesting impairment, even if subtle, what's the protocol?
It doesn't automatically stop surgery, but any findings suggesting impairment should promptly trigger a referral to primary care, mental health, or a geriatric specialist for further evaluation. Establishing cognitive impairment early has crucial implications for communication, assessing decision-making capacity, and ensuring truly informed consent, possibly involving a healthcare proxy.
This raises an even more important question about postoperative impact, particularly the risk of delirium, which sounds like a major challenge.
It is a profound challenge. Postoperative cognitive impairment is a very strong predictor of delirium, which has an alarming incidence of nearly 50% among geriatric patients after surgery.
Half? Wow.
Yes. Documenting pre-existing cognitive impairment preoperatively improves interpretation of perioperative mental status changes and encourages proactively avoiding medications known to precipitate delirium. Postoperative delirium has a profound impact, affecting length of stay, long-term cognition, cost of care, and even mortality rates. Because treatments for established delirium are few, studies focus heavily on identifying risk factors and prevention. To that end, the AGS Best Practice Guidelines for Delirium, detailed in Box 10.4, strongly recommend preoperative risk factor screening for all geriatric surgical patients.
What are those key risk factors to screen for? It sounds like a truly comprehensive health snapshot.
It is indeed. Key risk factors include age over 65, existing cognitive impairment, severe illness or high comorbidity burden, hearing or vision impairment. Other critical factors: current hip fracture, presence of infection, inadequately controlled pain, depression, or alcohol use. Lifestyle and physiological factors like sleep deprivation, renal insufficiency, anemia, hypoxia, or hypercarbia are also significant. Poor nutrition, dehydration, electrolyte abnormalities are important. Finally, poor functional status, immobilization, polypharmacy, especially psychotropics like benzodiazepines, anticholinergics, antihistamines, antipsychotics, risk of urinary retention or constipation, presence of a urinary catheter, and specific procedures like aortic operations are all recognized risk factors.
It's almost like a comprehensive checklist. And identifying these factors helps prevent second-hit insults, like high-risk meds or sleep disturbance.
Precisely. Early identification raises awareness and enables proactive measures. It encourages avoiding those second-hit insults and promotes simple, effective measures to improve orientation. Things like ensuring the patient uses hearing aids glasses, encouraging good sleep hygiene, and actively involving the family for reorientation during recovery. Small details, big impact. Beyond cognition, depression is another silent yet significant risk factor. Increased comorbidity and medical burden can exacerbate depressive symptoms. Additional risk factors include sleep disturbance, low functional status, lower education level, and heavy alcohol or polysubstance use.
So depression isn't just mental health. It has direct surgical implications.
Absolutely. The implications are profound. Elderly patients with preoperative depressive symptoms can experience postoperative delirium more often and for longer. Depression may lower the pain threshold and predicts chronic postoperative pain. In the ICU, it's associated with increased mortality and reduced quality of life post-discharge. After cardiac surgery, depression and anxiety may even increase the likelihood of coronary disease recurrence and mortality. The ACS NQ-PAGE guidelines recommend the PHQ-2 for screening. Positive findings need referral. Optimal management is multidisciplinary, often involving meds and cognitive behavioral therapy.
The ACS NSQ-PAGE framework strongly emphasizes a comprehensive medication history for older patients, including over-the-counter meds, eye drops, vitamins, herbals. This must be an enormous task.
It is, but crucial. By meticulously reviewing all medications, risks of adverse drug reactions, inappropriate dosing, and polypharmacy can be identified and avoided. This involves considering changes in drug metabolism and clearance in the perioperative setting, as older patients handle drugs differently under stress. Regarding common meds, ACHA guidelines support continuing beta blockers for patients already on them. For intermediate risk surgery, patients with known coronary artery disease or significant risk factors, initiating beta blockade may be considered. But if initiated, start weeks before elective surgery and titrate carefully to a target heart rate of 60-80 BPM. What's vital to understand is the risk of initiating too close to surgery. Rapid initiation can increase risk of stroke, hypotension, and death. So for patients with limited cardiac risk factors, rapid initiation preoperatively is not indicated.
And what about medications generally inappropriate for older adults, especially perioperatively?
That's where the AGS-Beers criteria are relevant. These guidelines identify meds with high-risk adverse effects for older adults: drug interactions, impaired clearance, sedation risks, predisposition to delirium. Some, like benzodiazepines, are categorically contraindicated as they significantly increase risk of cognitive impairment, delirium, and falls. Understanding and avoiding these, or weaning carefully, is key to geriatric safety.
This is fascinating, moving beyond age to assess physiological reserves. Elderly patients with functional limitations, impaired ability to perform daily tasks, have more complications, discharge to facilities, and higher mortality. And this is magnified in patients over 80.
Absolutely. Age alone is a poor predictor. A simple indicator is a history of falls. More detailed tools include activities of daily living, ADLs, and instrumental activities of daily living, IADLs, in Box 10.5. ADLs cover basic self-care: bathing, dressing, toileting, transferring, continence, feeding. IADLs are more complex, using the phone, shopping, cooking, housekeeping, laundry, transport, meds, finances, deficit signal, reduced reserve.
And the patient's social context is crucial here too.
Yes, social and family support systems are interwoven with functional level. Their living situation independent, with family assisted living has implications for health, postoperative disposition, and recovery. Incorporating this social context is vital for successful, patient-centered recovery and managing expectations.
So if age is a poor marker, but frailty is more accurate, how is frailty defined and measured?
While no single definition exists, the AGS suggests frailty is a syndrome. weakness, fatigue, weight loss, decreased balance, low activity, slowed motor processing, social withdrawal, cognitive changes, vulnerability to stressors. Its impact is huge, associated with major complications and mortality across surgeries. The source highlights a large NSQIP study showing frailty index was a stronger predictor of cardiac arrest death than ASA class or MI history.
That's profound. How is it measured in practice then?
It can be measured using exhaustive scales like CGA or pragmatic tests like the timed up and go TUG tool measuring functional mobility. As shown in figure 10.2, the TUG test measures time to rise from a chair, walk 3 meters, turn, return, and sit. In one study, TUG 20 seconds was linked to a 50% risk of major complications in patients over 70 versus 14% for TUG 20 seconds. Gait speed alone outperforms some scales in predicting cardiac surgery outcomes. While function is easy to measure, comprehensive scales like CGA yield more actionable results for preoperative optimization. Patient counseling is integrated into informed consent, representing clear, collaborative communication about individualized treatment goals.
It's critical for the patient to have clear and realistic expectations about the treatment course and potential complications.
Absolutely. For older patients, having this discussion with their anticipated postoperative support system, spouse, children, nurse, is highly recommended. This ensures everyone is informed, especially if the patient has cognitive impairment. And regardless of baseline state, older patients anticipating elective surgery should arrange for an advance directive and designate a healthcare proxy. These documents must be prominent in the medical chart.
Now let's shift focus to how surgeons prepare the entire body for surgery, system by system. We begin with the cardiovascular system. With the aging population, more patients with heart disease undergo non-cardiac surgery. Perioperative cardiac complications are a major focus due to morbidity, mortality, and cost.
True. However, what's crucial, and perhaps counterintuitive, is that preoperative cardiac intervention, like bypass or stent, solely to reduce non-cardiac surgical risk, is rarely needed. It's typically only indicated if needed for the patient's baseline cardiac condition anyway. The goal of cardiology evaluation isn't clearance, but providing information on cardiac risk and management options. The guiding principle for testing: only pursue it if there's a reasonable likelihood it will change management.
What kind of changes would justify additional cardiac testing?
Significant changes: delaying the operation, preoperative revascularization if independently indicated, medical optimization, modifying perioperative monitoring, or referral to a specialty center. The ACHA guidelines from 2007 to NO14 identified 3 surgery-specific risk categories. To elaborate: high-risk surgery, cardiac morbidity 5%. Vascular surgery, aortic, peripheral endovascular fits here. Intermediate risk surgery, morbidity 1-5%. Abdominal, thoracic, carotid, endarterectomy, orthopedic, head neck surgeries, low risk surgery, morbidity 1%. Endoscopic, superficial, cataract, breast, ambulatory operations. Crucially, for patients undergoing low risk operations, regardless of other factors, no preoperative cardiac testing is indicated.
And the Revised Cardiac Risk Index, RCRI, in box 10.6 seems the most pervasive tool. How does it work?
Yes. Published in 1999, it's popular for simplicity and objectivity. It assigns 1 point each to 6 factors: high-risk surgery, ischemic heart disease, history of CHF, history of cerebrovascular disease, insulin therapy for diabetes, preoperative creatinine 2.0 milligdL. Patients are classed IIV based on 0.0, 1, 2, or 2. It has moderate discriminatory power, but its advantage is ease of use. The ACS NSQIP calculator is also endorsed as an alternative.
So let's walk through the stepwise approach to testing for coronary artery disease, as in figure 10.3, a key decision algorithm.
It is indeed foundational. First, determine urgency and risk factors. Assess urgency, emergency, urgent, elective, and identify cardiac risk factors. Emergency ops proceed, risk factors guide monitoring. Second, assess for acute coronary syndrome, ACS, and functional capacity. For urgent elective, assess for ACS, like MI. If suspected, refer to cardiology. Critically, estimate functional capacity in MATEs, table 10.4. If METs were for without symptoms, they can usually proceed. Third, further testing based on combined risk function. If no ACS, testing depends on combined risk factors and functional capacity. If it's a low-risk operation, regardless of factors or function for MUTs, no further testing is needed due to low risk.
But if they're at elevated risk and have poor unknown function, for METs, and testing would impact decisions.
Then a pharmacologic stress testing, dobutamine stress echo or stress MPI, may be indicated, especially if they have U3-RCRI factors and can't do exercise testing. The key point is stress repeatedly. All tests should only be pursued if there is a realistic likelihood that the obtained data could change management. If not, it's unnecessary.
What about specific tests like ECG or echo? When are they indicated?
A 12-lead ECG is indicated for non-low-risk ops, especially with known coronary arrhythmia, peripheral artery cerebrovascular disease. Even asymptomatic, consider ECG except for low-risk ops. Echo to assess LV function is reasonable for dyspnea of unknown origin or progressive heart failure. If known LV dysfunction, consider echo if not assessed within a year or if functional status symptoms changed. Importantly, coronary revascularization solely to reduce perioperative cardiac risk is generally not indicated. It's only done if already indicated by baseline guidelines for the heart condition itself.
And if PCI, stent, is indicated preoperatively, what about timing for subsequent non-cardiac surgery? A delicate balance.
Very delicate. For elective non-cardiac surgery after recent revascularization, delay is crucial. Minimum 14 days after balloon angioplasty, 30 days after bare metal stent, BMS. Ideally, delay elective surgery for a full year after drug-eluting stent, DES, due to need for dual antiplatelet therapy, DAPT. However, if risk of further surgical delay outweighs stent thrombosis risk, an operation with managed DAPT interruption can be considered after 180 days post-DES. Direct communication with cardiology is imperative.
What about other high-risk cardiac patients? When is the risk truly too high?
Patients with moderate severe left-sided heart failure, right-sided heart failure, significant pulmonary hypertension, 25 mm Hg, and severe aortic stenosis, 1 cm Martyr, are at significantly increased risk of death. Elective urgent ops require a multidisciplinary approach and extensive risk-benefit discussion. Medical optimization or preoperative valve replacement might be options, but for those whose function can't be improved, the risk of surgery can exceed the benefit and non-operative management should be considered.
Now, perioperative cardiovascular medications. Beta blockade reduces cardiac events but not necessarily mortality and has risks. What's the nuanced recommendation?
SCAH guidelines. Continue beta blockers if they are baseline meds. For intermediate high-risk ischemia or U3 RCRI factors, initiation can be considered. However, treatment should ideally start 7 days prior to surgery. Rapid initiation risks stroke, hypotension, death. For limited risk factors, rapid initiation is not indicated.
And statins.
Continue statins if already taking. If not on statins but undergoing high-risk surgery, SBI vascular, initiate statin treatment.
Antiplatelet therapy seems complex, especially after stenting.
It is. Management requires consensus, surgeon, anesthesiologist, cardiologist. Generally, perioperative aspirin monotherapy is safe for most operations. Unless surgical bleeding risk outweighs stent thrombosis risk, DAPT should be continued for 4 weeks post-BMS and 6 months post-DS. If a P2Y12 inhibitor must be stopped, continue aspirin if possible, and restart P2Y12 inhibitor ASAP post-op.
Here's where it gets really interesting again. For patients not already on aspirin, initiating it perioperatively is not supported by evidence. The POISE-2 trial showed no benefit on DFMI, but increased major bleeding.
A profoundly important point, reflecting evidence-based practice. POISE-2 fundamentally changed practice. Sometimes less intervention is more. Now, anticoagulation. Balancing bleeding versus thromboembolic risk, including bridging. High-risk thromboembolic patients, recent stroke, high-risk AFib, shouldn't have elective ops until risk is optimized. Low bleeding risk ops, many cutaneous, can proceed without interrupting anticoagulation. ACCT 2012 guidelines are widely accepted.
How does warfarin fit in with its long half-life?
Challenging. Discontinue 5 days before elective EPS. Check PTINR day of surgery, target 1.5. If high, vitamin K or FFP. Takes 4 to 5 days to reach therapeutic levels on restart. Restarting within 24 post-op means 8 to 9 days subtherapeutic anticoagulation.
This means bridging is often considered for high-risk patients.
Yes, for very high risk. Recent stroke, embolism, mechanical valve, high-risk VTE. However, bridge trial found foregoing bridging in AFib didn't increase thromboembolism and decrease major bleeding. Influenced practice significantly when bridging. Stop unfractionated heparin 4-6 hour pre-op, low molecular weight heparin 24-hour pre-op. Resume therapeutic LMWH 48-72 hour post-op for high bleeding risk ops.
And the newer DuoX, dabigatran, rivaroxaban, etc. in table 10.9. Advantages.
Significant advantages. Rapid onset, 4 apps, shorter half-lives allow shorter interruption, no routine monitoring needed, need precise knowledge of kinetics and reversal options. Specifics. Dabigatran, direct thrombin inhibitor, renal clearance, half-life 12-17 hour, hold 48 hour pre-major surgery, normal renal fecus, resume 2/3 D post-op, monitor with anti-ZAC assay, renal hepatic clearance, CYP3A4, drug interactions common, P450 inhibitors inducers, PGP transporters, monitor with anti-ZAC, short half-lives, stop 48 hour pre-op, resume 2/3 post-op, reversal agent, Endexanet alpha, Endexa, approved 2018.
Next, the pulmonary system. Postoperative pulmonary complications, PPCs, occur in 6% after major abdominal ops, linked to increased mortality, ICU admission, longer stays, a key focus.
Indeed. Major categories: pneumonia infection, respiratory failure needing ventilation, COPD exacerbation, lobar collapse. ACP and ARISCAT study provide guidelines.
What are the key patient-related risk factors for PPCs?
Age 50, ASA class II, functional dependence, hypoalbuminemia 3.5, COPD, heart failure. Interestingly, CHF, especially with pulmonary hypertension, is a stronger predictor than severe COPD. Active smoking increases risk, but cessation on 4 weeks prior reduces it. Obesity itself isn't clearly linked, but OSA and obesity hypoventilation syndrome definitely are.
And procedure-related risk factors.
Vascular, thoracic, abdominal neurosurgery, general anesthesia versus regional, head neck surgery, duration 3R, emergency surgery. PPC likelihood increases closer the incision is to the diaphragm. Regional anesthesia should be considered for high-risk patients.
How does the preoperative pulmonary evaluation proceed? What tests are useful?
Starts with thorough history physical. Spirometry indicated for assessment before pulmonary resection, suspected undiagnosed COPD, or existing copidasma if baseline unclear from H&P. Not for routine screening if results won't change decisions. No prohibitive spirometric threshold for non-thoracic surgery. Routine chest x-ray maybe for 50 years undergoing high-risk surgery. CT often used for staging. Pulse ox, FbO2, is a risk factor in ARISCAT, easy for routine screening.
Are there predictive indices for pulmonary complications, like for cardiac risks?
Yes, most cited. Arizula Index, ARISCAT Index, Gupta Respiratory Failure Calculators, ARISCAT Index, Table 10.5, simplest, 7 predictors: age, pre-op SpO2, rest infection last month, pre-op anemia, surgical incision, duration, emergency. Disadvantage may overestimate, includes minor morbidities. Classifies low, 26, intermediate, 26, 44, high or 45 risk. Arizula Index, more cumbersome, 12 factors, targets respiratory failure, Gupta calculators. From NSQAP dataset, target rest failure pneumonia, available online app.
More detail on OSA and obesity hypoventilation syndrome.
Crucial areas. OSA, older age, obesity, male sex associated. Simple Stoppy-Bang questionnaire screen stratifies risk: snoring, tiredness, observed apnea, pressure high, BMI 35, age 50, neck 40 centimeter, gender male. O5 factors equals high risk, moderate, severe OSA. Elective, consider sleep study if positive, optimize with CPAP pre-op. Urgent emergent, manage OSA post-op. Obesity hypoventilation syndrome, BMI 30 with awake PACO2, 45 millimeter Hg, highest risk BMI 50. Hypoventilation worsened by anesthesia opioids. Post-op capnography and adherence to OSA screening CPAP use can decrease failure death risk.
Moving to the renal system. Patients with chronic renal insufficiency, CRI, especially on dialysis, face substantially greater perioperative morbidity mortality, higher pressure needs, longer ventilation, longer ICU hospital stays.
Take a high-risk group.
Truly high risk. Elevated risk stems from high rates of concurrent cardiac disease, perioperative fluid electrolyte disturbances, uremia-mediated bleeding diathesis, pre-op measures, thorough comorbidity assessment, optimized fluid electrolytes, secure resources, dialysis. CRI predicts death cardiac arrest. Cardiac risk assessed per CIA, RCRI. Do all CRI patients need extensive pre-op testing?
Not always. Stage 1 to 2 CRI, function 4 METs, low intermediate risk surgery usually don't need extra studies. Stage 3 to 5 CRI or high-risk surgery should get additional cardiac eval, ECG, CBC, chemistry, electrolytes, UA. Echo if volume overloaded despite optimal CRI management. Check for cardiac dysfunction.
What's critical for patients on dialysis?
Pre-op management focuses on fluid electrolyte optimization, hemodynamic stability, ideal dialysis timing, day before or day of surgery. Aim for near normal electrolytes, isopotassium, and euvolemia, near dry weight.
Hyperkalemia sounds like a major concern.
Life-threatening complication. Must be addressed pre-op. Normal potassium is prerequisite for elective urgent ops. Intra-op meds to counteract hyperkalemia are limited, can cause intra-op death. Increasing peritoneal dialysis pre-op. Data inconclusive. Goal, safe K+ before anesthesia.
What about preserving residual renal function in new dialysis patients?
Critically important for solute clearance fluid balance first year, confers long-term survival benefit. Preservation is key perioperatively. Evidence inconclusive, but consider holding diuretics, ACEI, ARBs perioperatively, hemodynamic changes. Resume early post-op, once stable, may preserve residual GFR.
And impact on hematology. Bleeding risk.
Chronic anemia common, low erythropoietin. After addressing causes, epidarropoietin for pre-op optimization. Platelet count okay, but uremic platelet dysfunction common. DDAVP for medical bleeding. Cryoplatelets if needed. Diligent dose adjustment for meds. Avoid nephrotoxins, NSAIs, aminoglycosides, ampho-B contrast, if residual function. If no residual function, can consider. Goal.
Avoid secondary renal insults, maintain volume BP.
Moving to the hepatobiliary system, liver, gallbladder, bile ducts, impaired liver function elevates risk for surgical anesthesia complications. Thorough histrophysical crucial for cues.
Absolutely. Liver central to metabolism, clotting. Acute hepatitis, viral, drug, autoimmune, obesity-related needs diagnosis, evil management. Contraindication to elective surgery can even indicate liver transplant in chronic liver disease like cirrhosis.
Fibrosis without cirrhosis usually tolerates elective surgery well. Cirrhosis, significant impact on planning outcomes. Risk factors: 5e drug use, alcohol, long-term obesity, family history. Symptoms: pruritus, jaundice, ascites, gynecomastia. Exam: spider telangiectasias, caput medusae, icterus, splenomegaly, fluid wave. Fascinating point. Routine pre-op LFT is not recommended for non-hepatobiliary surgery if no evidence of dysfunction, low predictive value. Targeted testing. For established hepatic disease, stratify risk by clinical scenario subjective measures. Common anesthetics need hepatic metabolism, careful dosing, altered volume distribution, slower elimination. Cirrhosis increases mortality across all major elective surgery. Or R 3.4 for cholecystectomy to 8.0 for CAB.
So what are the key objective measures for surgical risk in cirrhotic patients?
Three most common: Child-Tricot-Pugh, CTP score; Melita score, residual liver volume for resections; CTP score, table 10.6, popularized 1980s easy calculation, correlates with mortality as abdominal surgery. Class A, 536 people, well compensated. B, 7 to 9, significant compromise. C, 10-15, decompensated. Variables: encephalopathy, ascites, albumin, INR, total bilirubin, mortality estimates, abdominal ops. 10% CTPA, 20% B, 60% C, Melody score. Predicts survival initially for transplant selection. Supplanted CTP often uses only objective measures, bilirubin, creatinine, INR. 30-day mortality correlates linearly. MELD 8, 6% mortality, 20-50% mortality.
So the CTP versus MELD debate. Which is superior?
Ongoing debate. Some studies, MELD-14 better predictor than CTPC after abdominal surgery. Others, CTPA better for non-hepatic abdominal ops where MELD wasn't. Both may be more predictive for urgent versus elective ops. Key, appropriate pre-op selection optimization paramount for cirrhotic patients regardless of score. They're complementary.
Common general surgical problems in cirrhotic patients. Hernias, gallbladders.
Yes. Abdominal wall hernias, biliary tract disease. Significant poorly controlled ascites predisposes to hernias. Emergency repair for leaking ascites equals higher morbidity mortality. Pre-op ascites management paramount. Hernia repair. Suture closure, no mesh, feasible, safe. Cholecystectomy. Laparoscopic, better than open. Risk increases with CTP BC, MEL LD 1820. Multidisciplinary analysis crucial. Decompensated awaiting transplant. Repair hernia post-transplant. Delay cholecystectomy until transplant if possible.
And residual liver volume for hepatic resection.
Critically predictive of post-hepatectomy liver failure, PHLF, often defined by 50-50 criteria. PT 50%, normally in R 1.7, Billy 2.9 milli-GDL on POD5. PHLF has up to 50% mortality, non-cirrhotic, 20% residual volume adequate. Compensated cirrhosis, estimated 40%, estimated by CT-MRI volumetry.
How are these patients medically optimized preoperatively?
Synthetic function. Check PT, albumin, fibrinogen. Creatinine bilirubin for MEL-D, note. PT doesn't directly correlate with bleeding risk, can have hypercoagulability. Treat ascites, diuresis paracentesis, reduces dehiscence hernia risk. Renal function critical, impaired synthesis can lower urea creatinine artificially. Malnutrition common, poor outcomes. Pre-op nutritional supplementation, includes fat-soluble vitamins, if weight loss, prealbuminemia.
Moving to the hematologic system, blood, bleeding, clotting. Bleeding thromboembolism among most worrisome preventable complications. Thorough hematologic history physical for every patient.
Foundational. Evaluate for anemia symptoms, fatigue, pallor, hematochezia, dyspnea, palpitations, coagulopathy, petechiae, bleeding diathesis meds, hypercoagulability, thrombosis, edema. Exam vitals, hepatosplenomegaly, lymphadenopathy, skin tone, edema, rectal bleeding, thorough med reconciliation, antithrombotics, liver kidney function, impact, risk VTE prophylaxis.
Chronic anemia common. Healthy tolerate low HB. Trend in transfusion.
Significant shift from liberal to restrictive protocols. Lack of evidence for liberal measurable risks with transfusion. Table 10.7. Febrile reactions, taco, allergic reactions, trachea, infections, rare. Give only what's needed.
Current transfusion triggers. What HB level?
Always individualized. AABB 2016 guidelines based on 12K patients.
Yeah.
Most hemodynamically stable asymptomatic hospitalized patients. Transfusion not indicated until HbE 7 GDL. Includes critically ill, tri-ACC, trust trial support.
Exceptions to the 7 GDL threshold.
Yes. Patients with cardiovascular disease, those undergoing cardiac surgery might consider HUDL threshold. Trice assessed the trial, cardiac surgery, no difference between 7.5 versus 8.5 to 9.5 threshold. Focus trial, asymptomatic CVD.
Yeah.
HGDL not worse than 10 GDL. Less blood is safer for most.
Acutely bleeding patient.
Yeah.
Different scenario.
That's fundamentally different. Anemia linked to hypovolemic shock. Rapid instability makes lab-based protocols impractical. Stable ongoing bleeding, restrictive may be okay. Significant bleeding instability trauma, empiric transfusion, massive transfusion protocols can be life-saving. Restore volume O2 capacity first. Inherited coagulopathy. Routine pre-op screening discouraged. Workup guided by history, nosebleeds, menorrhagia, joint bleeding, hereditary disease, comorbidities, renal hepatic, increased risk. Prior procedures meds crucial. Exam, epistaxis, gingival bleeding, petechiae, platelet collagen, hemarthrosis, dehematomas, factor deficiency.
Low incidence, major bleeding, common ops, routine testing underpowered. If history of physical suggests risk, initial labs.
CBC, platelets, PTINR, APTT, creatinine, hepatic function panel, signs hereditary bleeding disorder, hematology consult.
Diagnostic workup for hereditary bleeding disorders. Figure 10.4 helps.
First step, separate coagulation versus platelet vascular disorders. PTINR, APTT normal. Suspect thrombocytopenia or platelet dysfunction. Spontaneous bleeding rare unless platelets 30K. Inherited. VWD most common. Bernard-Soulier, Glanzmann. Acquired. Cirrhosis, MDS, uremia, aspirin P2Y12, and SABs. Note, normal PTAP-RT doesn't rule out all coagulopathies, factor 13 or vascular. Isolated prolonged APTT suggests factor 8 hemophilia A, 9 exeophilia B, AB most common, X-linked recessive. Isolated prolonged PT, no warfarin cirrhosis. Rare factor 7 deficiency, both PTAP-PT abnormal, common pathway defect, factors 2V, X fibrinogen. Inherited rare, acquired more likely, VITK deficiency, warfarin hepatic insufficiency, DIC.
General principles for perioperative management of inherited bleeding disorders. Multidisciplinary.
Absolutely. Institutional protocols, collaboration, hematology, anesthesia, surgery. Varies by resources. Elective ops, ensure all lab therapeutic resources available post-op. Multiple 5-access away from infusion sites. Analgesia, avoid antiplatelet meds, aspirin and NSAIDs.
Specifics for hemophilia and VWD.
Hemophilia A, factor 8 deficiency, mild, 5%. DDAVP day of surgery raises 8 up to 5x in 90 minutes. Check levels pre-post, may redose, watch fluid retention hyponatremia, ASPOE elderly, severe. Factor 8 concentrates immediately pre-op, 10-20 minute pre-incision. Minimize repeat dosing, inhibitor risk up to 25% severe A-developed inhibitors. Prior factor replacement, screen for inhibitors weak pre-op, inhibitors present. Need bypassing agents are factor ABF. Hemophilia B, factor IX deficiency, no response to DDAVP. Even mild forms need factor IX replacement pre-post major surgery. Von Willebrand disease, VWD. Most common VWF mediates platelet adhesion, carries factor 8. 3 types, table 10.8. Type 1, partial deficiency, most common. Responds well to DDAVP1/8 pre-incision. Level stay up post-op, acute phase reactant. Type 2, qualitative defects, 2A to B2M. DDAVP partial response 2A2M, contraindicated in 2B thrombocytopenia risk. Type 3, complete deficiency, no response to DDAVP. Type 3, most type 2. VWF, concentrate treatment of choice. Measure pre-op levels, target levels tailored to surgery, e.g. 100% pre-major op, 50% daily trough.
Circling back to antiplatelet therapy. 2014 ACAH. Individualized approach weighing bleeding versus cardiac risks.
Yes. Chronic low-dose aspirin, no prior stent, generally continue perioperatively if bleeding risk low. Aspirin monotherapy, usually safe, most general CV ops.
After coronary stenting. Delicate DAPT management.
Critical. Avoid elective ops needing DAPT discontinuation within 38 post-BMS or 12 meter post-DS. Delay reducible to 6 meters post-DS if delay risks stent thrombosis risk. Urgent ops within 4W post-stent. Continue DAPT unless life-threatening bleed risk. If P2Y12 inhibitor must stop, continue aspirin if possible. Restart P2Y12 ASAP post-op. Big 10.5.
Really interesting point again. Patients not previously on aspirin, initiating it perioperatively is not supportive. POISE-2, no benefit on death MI, increased major bleeding risk.
Profound point, highlights evidence-based practice evolution. POISE-2, changed thinking. Less is sometimes more. Anticoagulation. Balance bleeding versus thromboembolic risk, bridging needs. High thromboembolic risk patients shouldn't have elective ops until risk optimized. Low bleed risk ops can proceed without interruption. ACCP 2012 guidelines most accepted.
How does warfarin fit in?
Long half-life, 36-42 hour, discontinue 5B pre-elective op, check INR day of, target 1.5. If high, VIT KFFP. Takes 4 5Bs to reach therapeutic levels, restarting 24 of post-op 890 subtherapeutic.
Means bridging often considered for high risk later.
Yes, for very high risk. Recent stroke, embolism, mech valve, high-risk VTE. But bridge trial. Foregoing bridging in AFib didn't increase thromboembolism, decrease major bleeding. Changed practice for non-valvular AFib when bridging. Stop UFH 4-6 hour pre-op, LMWH 24 pre-op. Resume therapeutic LMWH 48-72 hour post-op for high bleed risk ops.
And the newer DOACs, Davigate Tran Factor SAN inhibitors in Table 10.9.
Advantages: rapid onset 4 hours, shorter half-life, shorter interruption, no routine monitoring, need kinetics reversal knowledge, Davigatran, renal clearance, 12-17 hour half-life, hold 48 hour pre-major surgery, normal renal FX, resume 2/3 post-op, dose adjust elderly renal impaired, reversal EDAR, Sizumab, Prexpine, direct factor L inhibitors, monitor anti-assay, renal hepatic clearance, CYP3A4, drug interactions, rapid onset 2/4, short half-life, stop 48 hour pre-op, resume 2/3 post-op, reversal, Andexanet alpha, Indexit.
Next, the endocrine system. Comorbidities influence physiology. Beyond diabetes, thyroid adrenocortical imbalances, hormone-secreting neoplasms must be managed.
Indeed. Hormonal imbalances profoundly affect surgical response. Diabetes mellitus, nearly 10% U.S. pop. Chronic sequelae affect CV, renal, neurosystems, pre-op EVO, physical exam labs, ECG electrolytes, 4 long-term effects. HbA1c for glycemic control efficacy. Insulin management, long-acting, glargine aditamir. Administer as scheduled, intermediate, NPH zinc. Half-dose morning of surgery, resume normal once diet resumes, short-acting, regular Lispro, etc. Hold morning of surgery, pumps, basal rate during surgery, reprogram after diet, endoconsult for complex port control, oral hypoglycemics, sulfonylureas withheld day of surgery, DPP-4 inhibitors, gliptins typically given morning of, metformin morning of surgery, controversial. Historical lactic acidosis, risk data not corroborated by recent reviews, Cochrane, potential benefits noted, practice evolving, hyperthyroidism, thyroid panel, TSH, identify, hyperthyroidism suppressed pre-thyroid surgery, non-thyroid elective ops delayed until hyperthyroid addressed, asymptomatic hypo, start replacement anytime, symptomatic hypo, fatigue, weight gain, etc. Delay elective ops until medically corrected, adrenocortical system, functional adrenal neoplasms, FEO, ACC, paraganglioma, catecholamine overproduction, life-threatening perioperatively. Test all adrenal neoplasms for hormone production. Medical management, alpha-beta blockade before planned op. Avoid urgent ops without blockade, high morbidity mortality. Adrenal insufficiency, treated with glucocorticoid replacement. 1% U.S. pop uses glucocorticoids, traditionally high-dose steroid peri-op replacement. Recent data, not always needed. Low dose, 5 mg prednisone day, continue baseline, higher dose, can test HPA axis, low dose ACTH stim test. No response insufficiency, physiologic replacement indicated. Consensus guidelines, box 10.7, replacement based on stress of opiate for G, 5100 mg hydrocortisone IV, pre-induction, moderate major stress, taper post-op. Neoplastic endocrinopathies, solid organ neoplasms secrete hormones, functional pancreatic neoplasms, gastrin, insulin, glucagon, VIP, pre-op evil needed if tumor functional, carcinoid syndrome, often liver mets, serotonin hypersecretion, flushing, diarrhea, urinary 5-HIA diagnostic, symptomatic carcinoid, managed with somatostatin analog blockade, octreotide prior to surgery, long-standing symptoms, evil for valvular heart disease, tricuspid regurg, pulmonic stenosis regurg, if significant, address surgically before tumor surgery. Peri-op octreotide imperative, infusion large dose pre-induction, ongoing high dose for instability, wean post-op, SIADH, rare small cell lung neurosub trauma, maintain euvolemia, correct serum sodium.
Nutrition obesity, nutritional status vital, surgical stress, catabolic state, consumes energy protein.
Critical area, malnutrition perioperatively, impaired wound healing, increased infection, electrolyte abnormalities, organ dysfunction. Goal, optimize nutrition to counterbalance stress.
How is preoperative nutrition assessed?
Indicators, history weight loss, chronic illness, dietary history, incolacritus supplements, exam, BMI, temporal wasting, peripheral edema, muscle mass, skin turgor, petechiae, ecchymos, ulcers. Screening tools, nutritional risk screen, NRS 2002, most used, table 10.0S, higher score linked to complications, LOS, score of 3.3, or nutritionally at risk, needs care plan.
Protein status, focus on wound healing, Marcus limitations.
Yes, vital for healing. Serum indicators, albumin, long half-life, chronic prealbumin, short half-life, recent transferrin. BUT, albumin, prealbumin, negative acute phase proteins. Levels decrease in acute stress inflammation, less reliable perioperatively. Transferrin affected by serum iron, despite limits, large VAS study. Albumin 3.5, strong predictor early post-op morbidity mortality. Still clinically useful.
Nutrition supplementation, enteral versus parenteral. Prehabilitation evidence.
Enteral gut preferred. Avoids IV infection risk hyperglycemia, includes immune bolstering, glutamino omega-3s, maintains gut mucosa barrier, prevents bacterial translocation. Parenteral IV risks infection hyperglycemia. Prehab, VA-TPN study 1991. TPN overall more infectious complications. But UT, severely malnourished TPN patients had fewer non-infectious complications. Suggests role for TPN prehab in select severe cases. Recent data use NRS 2002 screening. Consider parenteral enteral prehab for severe malnutrition. Mildly malnourished, don't delay surgery. Post-op setting. Initiate enteral feeding early, within 24 hours. Key component ERAS protocols may reduce complications. Awaiting bowel function signs unnecessary. Upper GI resections. Early enteral linked to fewer infections, shorter LOS. Parenteral only if non-functional GI tract expected 7 days.
Obesity, risk factor, but obesity paradox.
Complex. Extreme is BMI, 40 or 18.5, associated with mortality morbidity. UT, mildly elevated BMI, 25-30, may have decreased morbidity mortality, obesity paradox. Reasons debated. Severe obesity still consistent risk factor, pulmonary CV/VTE infectious, longer op times LOS. Many outcomes due to comorbidities, CVD, OSA, OHS, HTN diabetes. AJ-REX, pre-op ECG-CXR for BMI 40 plus HF risk factor, poor exercise tolerance. Stopping insensitive for OSA helps direct polysomnography, anticipate difficult airway.
Preoperative consideration scare protocols. Day of surgery, surgeon's final check.
Critical moment. Query interval changes. Reevaluate meds. Timing last dose. Confirm anticoagulant antiplatelet management. Verify informed consent. Understanding objectives risks. Review important orders. Antibiotics, VTE prophylaxis with surgery anesthesia teams.
Patient recovery pathways like ERS. Core strengths.
ERA's best study supported. Introduced late 90s, early 00s colorectal strengths. 1. Standardization. 2. Pre-op patient education expectation management prehab assessment. 3. Intra-op anesthetic strategies, opioid avoidance, euvolemia. 4. Post-op care pathway, early mobilization, multimodal panopioid minimization, avoid volume overload, early diet. Holistic approach.
Proliferated across specialties.
Yes, ERAS type protocols across abdominal, general, thoracic, GYN, ortho, others, very granular. Timings for meds, patient expectations.
Key to success.
Engagement.
Definitely more than a checklist.
Yeah.
Patient buy-in, acceptance by multidisciplinary staff, surgeon, anesthesia, nursing, vital. Without commitment, compliance falters. Often show early improvements, infections, pain, LOS, but demonstrating long-term sustained effects elusive sometimes, adherence challenges. Standardized reporting compliance outcomes recommended to ID of best elements pathways.
Antibiotic prophylaxis. SSI is huge concern. Most common nosocomial infection, increased mortality, LOS. Our own skin bacteria responsible, largely. Commensal skin bacteria, staph, Pseudomonas, cause most superficial SSIs. Pre-op antiseptic skin prep, fundamental, reduces transient commensal microbes. CDC guidelines. Wide application area, concentric circles, dedicated instrument, adequate drying time. Hair removal, clipper only. Shaving increases SSI risk.
CDC wound categories, Table
No.
10.11, limitations.
Clean, contaminated, dirty, infected, useful academically, but recent research. Limited utility, frequent misclassification. Prophylaxis may be justified regardless for high-risk patients. Generally, prophylaxis not needed for clean wounds unless prosthesis anticipated.
Clinical Practice Guidelines 2013 provide specifics. Table 10.12, core principles for selection administration.
Core principles. Antimicrobial agent choice. Target common pathogens. Clean. Skin flora. Staph aureus, Conan S. Clean contaminated, abed, viscera, biliary, heart. Add gram-neg rodentera Kachi coverage. Common agents, cefazolin often preferred, low-cost spectrum duration. Cefoxitin, cefoxitin, vancomycin for MRSA colonization. Timing of first dose, within 60-minute pre-incision. Trial, lowest risk, 30-60-minute pre-incision. Longer infusion drugs, VANC, FQ. Start within 120-minute pre-incision, redosing. Maintain therapeutic levels, generally after every 2 half-lives or blood loss, 1,500 milliliter. Table 10.1. Duration. Minimal effective length. Most clean contaminated, no post-op needed. If indicated, 24-hour. Cardiothoracic, contentious, STS-REX. Consider up to 48-hour external wound risk, despite resistance this year. Diff risks. Pre-op review mandatory. SP-RO. Cardiac psych. Neurodiabetic. Anti-coagulatoplatelet.
General rules for these classes morning of surgery.
Cardiac drugs inhalers generally continued. Post-op parenteral substitutes if needed. Avoid therapeutic lapse withdrawal. Drugs impacting bleeding. Discontinue based on half-life. Institutional guidelines for timing withholding before local analgesic procedures, epidural, spinal block, reviewed pre-op clinic.
Herbal supplements, often overlooked.
Frequently underreported, like vitamins, OCPs, hormones. Estrogen amoxicillin held 4W pre-op VTE risk. Many herbals, Table 10.12, garlic, ginkgo, ginseng, impact physiology, bleeding risk, stop days, weeks prior. St. John's wort induces P450 enzymes, affects many drugs. Thorough history, vital.
Preoperative fasting. Aspiration risk, limiting intake, reduces gastric volume, but traditional protocols evolving.
Correct. Growing evidence prolonged fasting not universally needed can cause discomfort dehydration. ASA 2017 guidelines, table 10.15. Clear liquids, W or low carbs, permissible up to 2-hour pre-elective procedure, gestation. Breast milk up to 4-hour pre-elective.
Solid food.
Evidence for specific duration lacking. Current guidelines. Light meal permissible up to 6 hours pre-elective. Interval lengthened for heavier meals, higher aspiration risk patients. ASA does not recommend routine GI stimulants, antacids, antiemetics, anticholinergics solely to reduce aspiration risk shortened fasting. Use only if medically indicated otherwise. Goal: safety plus comfort.
Stepping into the operating room. Adequate preparation critical as patient selection evil. Involves systems, resources, and surgical equipment. Synchronized machine.
Absolutely. Meticulous prep ensures smooth, safe, efficient operation, minimizes challenges, allows focus on patient, systems-based resources, broader environment support. Or specifics: temp control, cleaning, availability, anesthesia team, pathology, consultative services.
Communication with anesthesia team imperative.
It is, especially with anticipated challenges, high-risk cardiac, liver, kidney disease, high-risk ops needing precise hemodynamic volume management. While ERAS standardized aspects, active, continuous, closed-loop communication between surgery and anesthesia vital for appropriate adaptive intra-op management, SBEC unexpected events, real-time adjustments.
Other, less obvious resources.
Meds products needed immediately. Analgesics, fluids, blood products, antibiotics, anticoagulants, vasoactive drugs readily available. Appropriate surgical assistance backup crucial. Despite planning, complex ops encounter unforeseen challenges. Immediate availability experienced partners consultative services verified before every op.
And the timeout process.
Yeah.
Figure 10.6. Key communication step.
Foundational patient safety measure. Standardizes immediate prep. Structured verbal confirmation before incision. Patient ID, site, procedure, consent. Check anesthesia machine meds, pulse ox functional, difficult airway aspiration risk, significant blood loss risk, allergies, site marked essential imaging reviewed. Team confirms names, roles, discusses critical steps, anticipated blood loss, patient concerns, confirms sterility equipment issues. Continually update all parties. Best practice. Closed loop communication, heard, understood, acknowledged. Surgical equipment varies by up. Common blading, functional table, instruments, monitors for imaging, suction, coagulation instruments, minimally invasive, insufflation, trocars, camera monitors, lap robotic instruments communicated, verified.
Patient positioning. Important for safety too.
Vital. Position securely, minimize pressure points, prevent neuromuscular injury, skin breakdown, obesilithotomy, risk compartment syndrome, SCP long ops. Fluid impermeable drapes downs create sterile barrier.
Maintenance of normothermia. Thermoregulation impaired by GA. Why? Risks of hypothermia.
GA lowers cold response threshold. Volatile anesthetics impair thermoregulation. Paralytics prevent shivering. Compensatory vasoconstriction downregulated. Neuraxial, epidural spinal, further blunts control, blocks vasoconstriction shivering. Effects additive, relevant with ERS, large cavity exposure, abdominal thoracic, significant heat loss, risk increases elderly, females, malnourished, long ops. Critical concern.
So, intraoperative hypothermia consequences.
Severe, wide-ranging. Impairs platelet aggregation coagulation cascade, nearly 13 increased blood loss, associated with increased wound infection. Alters drug actions metabolism, prolonged anesthesia, impairs acidosis electrolyte correction.
How is core temp monitored managed?
Close monitoring crucial. Accurate sites. Pulmonary artery, distal esophagus, tympanic membrane, nasopharynx, skin, forehead, ear canal, rectal correlate poorly. Hypothermia, most drastic first hour post-induction, rapid anesthesia-induced vasodilation, rewarming techniques critical during this period.
Rewarming techniques.
Passive or active. Passive insulation, blankets. Reduce cutaneous heat loss, 30%. Increasing room temp impractical for raising core temp. Active warming, forced air, air hugger. Effective during induction throughout. Most common. Ease, effectiveness, low cost. 4V fluid warming, relatively ineffective for raising core temp, but UT infusing ambient temp fluids cools patient. Any infusion 1 LH should be pre-warmed.
Preoperative skin preparation. SSI's 20% hospital-acquired infections. Our own skin bacteria are responsible.
That's right. Commensal skin bacteria, staph, Pseudomonas, cause most superficial SSIs. Pre-op antiseptic skin prep, fundamental, reduces microbes. CDC guidelines, wide application, concentric circles outwards, dedicated instrument, adequate drying time, hair removal, clipper only. Shaving increases SSI risk.
Different antiseptic solutions. Superior option.
Common. povidone iodine, betadine, chlorhexidine alcohol, chloroprep, iodine povacrolexisopropyl alcohol, duraprep. Avoid alcohol on mucosa. Optimal choice controversial. Past trials underpowered. Cochrane, 2015. Alcohol containing probably most effective, low evidence quality. Recent multi-institutional trial, clean contaminated. Chlorhexidine alcohol, lower SSI versus povidone iodine, 9.5% versus 16.1%. Colorectal trial, failed non-inferiority, Duraprep versus Chloroprep. Based on data, alcohol-based prep appears optimal.
Hemostasis, controlling blood loss. Meticulous dissection anatomy knowledge mandatory. Bleeding obscures field, prolongs time, increases stress, induces coagulopathy, complicates resuscitation.
Indeed. Long-term implications too. Certain cancers. Periop transfusion associated with increased recurrence, decreased survival. Minimizing blood loss is priority.
How are vessels controlled? Tiny to major.
Capillary small veins. Monopolar electrocautery. Vessels 1 millimeter, all named. Ties, clips, staples, bipolar electrocautery, ultrasonic devices, larger vessels, maybe suture ligation, prevent dislodgement. Traditionally permanent suture, absorbable suture, not associated, increased bleeding group. Rise of minimally invasive new devices, minimally invasive ties, endoloops, similar burst pressure to hand ties, stapling devices, vascular loads, tolerate lower but still supraphysiologic burst pressures. Illustrates effectiveness, various methods.
Wound closure. Clean, contaminated. Usually primary closure. Options for primary fascial closure.
Permanent or dissolvable suture, running or interrupted. Permanent, malnourished, debilitated, early follow-up expected. Dissolvable, subcuticular, cosmetic, no suture removal, high tension, vertical mattress sutures distribute tension to depths. Running suture, multiple layers, better control of sites. Interrupted, allows packing for high SSI risk incision.
Wounds that can't be closed immediately. Delayed closure.
Delayed primary closure. Select patients post-contaminated ops. Attempted 2-5-mate post-op. Some evidence reduces SSIs versus primary heterogeneity across trials. Heavily contaminated, dirty, leave open, heal by secondary intent, serial packing. Manage open wounds outpatient, often with negative pressure, vacuum device, temporary abdominal closure. Useful scenarios. Second look planned, compartment syndrome threat, monitoring needed. Usually non-adherent material bridge, plastic towel cassette cover, foam towels over, airtight seal with vacuum drain adhesive drape. Vacuum reduces fluid, allows monitoring, retention effect, counteracts retraction. Monitor fluid electrolytes, rapid shifts. Dedicated devices, VAC abdominal dressing, AB Thera, popular, ease of application. Delayed primary fascial closure, ideally within 7-10 pen. If not possible, serial closure, Whitman patch, Titan Q24488. Allows definitive closure when fascia closer, but suturing patch compromises fascia. Malnourished, can't tolerate pressure, absorbable mesh bridge. Visceral coverage, but loss of domain large hernia risk. Cutting-edge temporary repair. Bioprosthetic dermal matrices. Derived cadaveric dermis. Porcine human bovine. The cellular retains ECM basement membrane. Promotes fibroblast incorporation, collagen remodeling. Early revascularization, greater infection resistance versus permanent mesh. Collagen ECM is due to durable tensile strength flexibility versus absorbable mesh. Paucity, large published series. Recurrent hernia laxity may develop long-term. Evolving area. Adhesion prevention, barrier agents popular, these beyond multiple ops anticipated. Oxidized regenerated cellulose, PTFE, hyaluronic acid carboxymethyl cellulose, applied raw surfaces, degenerate gelatin, meta-analysis, GYN, low quality evidence, efficacy all three versus no treatment, relative efficacy unclear, ongoing challenge.
Surgical devices, energy sources, staplers. Tech advances revolutionize surgery, dissection to reconstruction.
Indeed. Changed how and what's possible. More precise, efficient, less invasive, energy devices, focus energy, dissection, division, coagulation, ablation, staplers. Traditionally alimentary tract, now vascular tissue transection. Let's delve in.
Electrosurgery, electrocautery. History to mid-1800s. Movie introduced modern 1914-27. Cushing popularized. Core difference.
Crucial distinction. Electrocautery. Thermal conduction via probe heated by direct current soldering iron. Heat generated in tip. Common. Portable pen cautery. Electrosurgery. Conduction alternating RF current through circuit completed by patient tissue. Heat generated by tissue resistance. Fundamental difference. Monopolar electrosurgery. Generator, handheld electrode. Small contact area, focus heat. Large return pad, dissipates energy. Circuit through patient. Continuous waveform, cuts tissue, little thermal spread, minimal coagulation, vaporizes water. Intermittent waveform coagulation, current 10% time. Lower thermal energy, greater spread, both electrodes in one instrument. Forceps. Tissue between complete circuit. No grounding pad needed. Minimal thermal spread beyond tissue between electrodes. Compressing tissue excludes blood, improves heat delivery. Useful near vital structures, safe with implants. Ligature and seal. Sophisticated bipolar fusion devices. Transmit current between adjacent electrodes. Apply uniform compression, monitor tissue impedance, adjust energy delivery, minimize thermal spread, seal larger vessels, up to 7 millimeter. Denaturation cross-linking collagen elastin, natural tissue sealant, blade divide seal tissue, efficient cut and seal.
Saline-cooled RF dissectors. Address Escher problem.
Yes. Frequent issue RF in vascular tissue, dense Escher, insulator, limits coagulation, delayed hemorrhage risk. Forms when surface temp needed for denaturation. Saline-cooled, tissue-linked aquamantes. Direct saline stream to contact point maintain surface temp, 105 degrees C, prevents excessive charring char. Common solid organ parenchyma, liver kidney. Initial capsule division needed, prevent steam. Constant pressure, consistent coagulation depth before sharp transection clipping larger vessels. Cleaner, safer. Ultrasonic dissectors distinguish high freak oscillation, cutting coag, from true ultrasonic energy, shattering e.g. lithotripsy for kidney pancreatic stones.
So high freak oscillation, harmonic scalpel, how does it work?
Transduces high freak ultrasonic energy via metallic jaw mechanical vibration, up to 55K movement SESEC, contact with tissue, vibration active blade against static blade vaporization plus coagulation. Compression increases coagulation, energy modifiable. High energy, rapid cutting, low energy promotes coagulation. Mechanism is vibration activates tissue without separate cutting blade. Versatile dissection hemostasis, SBL out laparoscopy.
And Cabotron Ultron Surgical Aspirator, CUSA. Unique mechanism application.
CUSA also uses ultrasonic vibration, but primary purpose, selective parenchymal tissue dissection, liver, brain, kidney. Hollow tip vibrates longitudinally by fragments tissue. Fascinating selectivity. Hepatocytes, high water, susceptible to fragmentation. Endothelium, epithelium, vessels, bile ducts, low water, selectively spared. Precise dissection plane via fragmentation preserves vital structures, tied separately. CUSA itself doesn't seal vessels, used with adjunct hemostasis. Tip can connect to monopolar circuit for ablation.
Ablation technology. Targeted tissue destruction. Radio frequency. Ablation. RFA. Powerful tool.
It is. Delivers RF energy via narrow probe. Esophageal dysplasia, AFib, solid organ tumors. Directed percutaneously or open lap. Electrode tip transmits high-freq AC kinetic thermal energy denaturation coagulation kills cells. Needs grounding pad, like monopolar. Implants metallic clips, contraindications. Tissue Escher can insulate, limit radius. Near blood vessels, heat sink effect limits efficacy. Typically tumors up to 3 centimeter defective, plus 0.5 centimeter margin healthy parenchyma.
Microwave ablation. Advantages over RFA.
Offers several advantages. Microwave energy between I radio waves oscillates polar molecules. A. Frictional heat, coagulative necrosis. Percutaneous or open MIS, image guided. Advantages versus RFA. Larger, more homogeneous ablation zone. Attenuated heat sink effect, less time needed. Crucially, no electric current transmission, no grounding pad needed. Safe with metallic clips implants. Rising popularity, preferred tech solid organ tumor ablation, liver kidney.
Other energy devices. Argon beam coagulator, ABC. Not a laser.
Correct. Adaptation monopolar electrosurgery. Focused beam argon gas conductor directed at tissue. RF current transported from electrode to tissue across argon pathway.
Advantages. Usefulness, broad surfaces.
More rapid activity, shallower penetration, faster heat dispersion versus conventional electrocautery. Argon jet disperses blood-dry environment, promotes coagulation, reduces Escher, most suitable hemostasis over surfaces, solid organs, spleen, liver, kidney, lung, peritoneum. Diffuse sealing.
Versatile. Limitations, safety.
Low penetration depth, ineffective larger vessels. Focused argon jet, insoluble in blood, direct targeting central veins, cardiac arrest risk, air argon embolism. Minimize risk. Low flow rate, angled approach, avoid direct deployment, large veins near right atrium.
Surgical staplers. Rich history, 1907 Budapest. Popularized Soviet Union, 40-50s. U.S. development, 60-70s, optimized design, disposable cartridges.
Right. Early models handmade, non-interchangeable, individual staple loading. U.S. commercialization, mass production, interchangeable disposable cartridges, variable heights. Enhanced utility, efficiency, adoption.
A multitude of types now. Uses.
Indeed. Facilitate closure, division, reconstruction, open lap robotic. Linear cutting staplers, for example, GI anastomosis, very length staple height, variable thickness tissues, multiple rows staples plus simultaneous cut. Linear non-cutting staplers, thoraco-abdominal, Tissue closure without division, strong seal. Circular cutting staplers, for example, end-to-end anastomosis. Luminal anastomosis transection, hollow viscera, variable diameters, circular staple line plus removed tissue ring.
How are staple heights chosen?
Smaller staples, 2 millimeters open, 1 millimeter closed. Vascular closure transection, larger, 4.5 millimeter open, 2 millimeter closed. Thicker tissues, stomach, pancreas. Number in between heights, commercially available intermediate tissues. Precise tool for tissue thickness, optimal compression.
Potential causes, intraoperative instability. Rare with proper prep, but management needs anticipation. Common deadly causes.
Understanding why, how critical for mastery, being ready for unexpected pre-planned response, malignant hyperthermia, MH, acute hypermetabolism episode, triggered volatile halogenated anesthetics, sevoflurane, iso, plus succinylcholine. Symptoms anytime during GA or up to 60-minute post-cessation.
Telltale signs.
Sheeper hyperthermia, tachycardia, tachypnea, increased exhaled CO2, rhabdomyolysis, metabolic disarray, hyperkalemia, acidosis. Fascinating early sign. Increase in end-tidal CO2 despite an increase in minute ventilation. Body producing excessive CO2.
How common? Genetic link.
Prevalence 1.1 K, 1.250 K. Anesthetic cases higher among susceptible. Genetic abnormalities, most common RR1 mutation, usually autosomal dominant, incomplete penetrance. Family history key.
Immediate treatment. Emergency.
Immediate decisive action critical. Discontinue volatile gas succinylcholine, IV dantrolene, 2.5 mg/kg, redose Q10, 15 minutes, ongoing fever, acidosis, rigidity. Aggressive body cooling, ice packs, cool IV fluids. Supportive measures, arrhythmias, hyperkalemia, acidosis. Typically ICU management. Mortality decreased significantly, 60 to 80% and 5% with advances. Gas embolus, air CO2, potentially venous circulation. Air via planned venotomy, great vessel repair. CO2, usually unplanned insufflation. Both. Abrupt decrease in end-tidal CO2 and cardiovascular collapse are the first manifestations. Dramatic, immediate, rapid recognition, resuscitation needed.
Management.
Terminate maneuvers allowing gas access, clamp vessel, deflate insufflation. CPR, pharmacologic plus mechanical. Intraop TE confirms diagnosis. Visualize gas, right access. Air aspiration attempt. Trendelenburg may be helpful. Left lateral decubitus only if no CV collapse. Can't do CPR. Patent foramen, oval risk, LV collapse, cerebral embolus. Mortality, 20%. MIPE, pneumothorax. Rare elective general surgery with proper EVIL. More common, urgent emergent trauma.
How identified under anesthesia?
Intra-op monitoring key. Hemodynamic instability, tachycardia, hypotension. ECG changes dysrhythmia signal, ischemia infarction. Classic ECG, new ST elevation diagnostic. Troponins corroborative stable. Suspected MI plus instability. Abort non-emergent op. PE rarely suspected without hemodynamic instability. Symptoms. Significant tachycardia, hypotension, hypoxia despite high FiO2 CV collapse. TE evaluates right ventricular dilatation failure, right heart strain. Absence makes significant PE less likely, with strain. Consider RV failure from MI, PE, pneumothorax. Treatment depends on symptoms. Terminate elective op if unstable.
Pneumothorax during surgery. How ID managed?
Multifactorial etiology, iatrogenic lung injury, central line, high ventilator pressure, diaphragmatic injury, high lap insufflation pressure, large amount air retention, hemodynamic instability impedes venous return, hemodynamic inspection, bulging diaphragm, absent sounds, bulging diaphragm. Tube thoracostomy indicate improvement. If resolves, may consider completing elective op.
Hemorrhage. Uncontrolled bleeding. Major vascular injury. Rapid blood loss. Life-threatening. Difficult control. Compromises field.
Immediate surgical steps. Focus vascular control. Arterial injury. Direct compression plus proximal control. Best first steps. Control via compression. Proximal isolation clamping. Combo repair.
Difficult situations. Can't compress reach.
Proximal control. Supraceliac aortic compression. Retract stomach. Divide gastrohepatic leg. Compress aorta against vertebrae. Hands free. Incise peritoneum. Separate diaphragmatic caris. Expose thoracic aorta. Apply clamp. Buys time for resuscitation. Major venous injury. Compression venotomy plus direct suture repair often possible. Bleeding prevents visualization. Venous compression proximal distal. Adequate exposure retraction paramount. Best prep. Sufficient dissection exposure allows management before hemorrhage.
Extreme cases. Trauma. Definitive control not possible.
Severe trauma, multiple sites, coagulopathy, hypothermia, bleed, sepsis, acidosis. Instability, definitive control impossible and practical. Best served. Damage control resuscitation. Goal-directed blood products. Temporary abdominal packing. Ongoing ICU resuscitation. Delayed definitive hemostasis, return to OR or angioembolization once stable. Prioritize stopping bleed stabilizing over immediate full repair.
Outpatient surgery. Volume increased dramatically. Driving forces.
driving forces: improved risk assessment, peri-op management, cost differences, outpatient versus inpatient, patient satisfaction, increased ASC use, ASC's expanded access without increased mortality, unplanned admissions. Surgeons must determine indications independently, resist induced demand. Benefits: reduces time off work, improves patient perception recovery. But caution needed selecting patients' cases.
Patient selection pre-op assessment for outpatient.
Tailored patient top type. Generally only low risk, some intermediate risk ops appropriate. Examples: elective plastics, inguinal hernia, elective col, superficial excisions, many head neck ortho.
How assess risk factors for outpatient?
ASA 1 to 2, low risk ops. Assessment day before or morning of, higher risk. Dedicated pre-op anesthesia clinic, time for additional testing if needed. Goals: 1. Assess appropriateness outpatient. 2. Direct pre-op testing risk strat. 3. Reduce day of surgery cancellations.
How assessments performed?
Pros cons.
Physician, reliable, comprehensive, costliest, extended provider, NPPA, nurse, standardized questionnaires, inexpensive, rely patient perception. Nurse questionnaire, reassessment day of surgery by surgeon anesthesiologist advisable. Risk factors, unplanned admission mortality, outpatient. Advanced age, prior recent hospitalization, invasiveness of operation, specific populations.
Exclusions.
Additional considerations. Generally, significant cardiopulmonary comorbidity not optimized, not suitable.
For obese patients.
Always excluded.
Increased risk bronchospasm, hypoventilation, obstruction, not strictly prohibited. Supermorbid obesity, BMI 60, generally absolute exclusion. Careful selection support paramount otherwise.
Organ system specific exclusions.
Cardiac. Unstable angina, at-risk myocardium, cardiomyopathy, mod severe HF, severe pulm-HTN, valvular disease. Pulmonary. Non-compliant OSA, stop bang, 5+ anticipate post-op opioids, suffering-controlled asthma, CF, home O2 use, hematologic. Coag disorders needing post-op factor infusion procoagulants. Renal. ESRD plus additional organ dysfunction, interval 2 lung short dialysis up, uncertain K+ or K+ 5.5. Pregnancy. Complicated pregnancy, fetus 21W gestation, other high risk. Muscular dystrophy, highly contagious airborne infection, TB, high hemorrhage risk. Chronic reflux, difficult airway, poorly controlled diabetes, also heightened risk. Consider only at centers with admission capability, safety net needed. Supportive resources post-discharge. Patients need adequate support after sedation, patient needs ride home, adult available overnight. Crucial pain nausea management. Ideally, emergency care accessible nearby. Absence outpatient resources, consider elective post-op hospitalization for observation. Prioritize safety.
So what does this all mean for you, our listener? We've journeyed through the incredibly detailed and meticulous world of preoperative and operative surgery. From the initial, deeply human patient-surgeon relationship to the most intricate molecular mechanisms, and all the way to discharge considerations, every step is a carefully calibrated decision, weighing risks against benefits, leveraging cutting-edge science.
We've seen how patient-centered care extends far beyond the OR, encompassing comprehensive evaluations, nuanced risk assessments using sophisticated tools, and personalized management plans for specific conditions: cardiac, pulmonary, renal, hepatic, hematologic, endocrine. The sheer depth of planning, foresight, and collaboration required for a successful outcome is truly remarkable, demanding a deep mastery of complex information, just as you saw today.
It makes you appreciate that surgery is truly the ultimate team sport, with constant communication, real-time adaptation, and an evolving understanding of best practices, like ERAs, protocols, and new energy devices. We've covered everything from tiny nuances of coagulation to broad considerations of outpatient care, aiming to provide you with an elite, professional-level understanding.
What's truly fascinating here is how this field continues to evolve so rapidly, with new technologies and evidence constantly reshaping approaches. Yet the fundamental balance between advanced technology and the human element surgeon's judgment, patient's trust, meticulous care from the team, the vital support system remains unequivocally at the heart of it all. It's a testament to the blend of science and art.
This deep dive should equip you with an elite understanding of the principles of modern surgical practice, allowing you to appreciate the complexity and precision like never before. The question for you now is, given this profound understanding of how interconnected every system is, what aspect of surgical care will you look at differently the next time you or someone you know faces an operation?
Keep those questions coming. And remember, the more deeply you explore, the more comprehensively you learn.
Until next time, stay curious.